I'm very pleased to be here today with two of my colleagues, Nancy Leathers and Ahmed Aldulaimi. We are very excited today to talk to you about network adequacy, which is something that is near and dear to our hearts, and to share with you how GIS is such a critical tool in this effort. First, let me introduce my colleagues. Nancy Leathers is with us as the director of the Geospatial Service Support Center, which is part of the Veterans Health Administration Chief Strategy Office. This group provides support for network adequacy and other geospatial activities, and we're very pleased to have her as part of this panel. Ahmed Aldulaimi is part of the Kaiser Permanente's National Provider Data Management Department. He also works with provider network reporting and analytics and brings a wealth of information from his experience there. So I'm very pleased to have them both with me, and we will be talking, as I mentioned, about network adequacy. Network adequacy is something that we refer to in the healthcare field to refer to how many providers are available to take care of a group of people. So in fee-for-service, when we pay for services one at a time, we think about networks and how many providers there are to take care of those patients. Within the Medi-Cal program, which is our Medicaid program here in California, we have a fee-for-service network, as well as a number of managed care networks. In our managed care networks, the managed care plan is responsible for taking care of patients and having enough providers to care for those individuals. In either case, we start off with a population that needs to be cared for and a number of providers that are there to take care of them. When we start adding the word adequacy, this means that we're going to measure how good our network is. Does it have enough providers? Are they close enough to where people live to be able to reach them? And do they have the right kinds of specialties in that network? So the network is a very important part of our healthcare environment, and we want to make sure that we can provide the highest quality services to the beneficiaries, to the patients, to the members of our care teams and our organizations. So over the years, the way we think about networks has been transforming and building a lot more complexity. There are a number of rules through federal regulations and state law and state regulation that dictate and describe how we want to approach our networks. Some of the more recent statutory language at the federal level was passed in 2016. And when that statute was passed, it was put a significant focus on a lot of components of managed care in both the Medicare and Medicaid programs. So the Centers for Medicare and Medicaid Services issued the Medicaid and CHIP Managed Care Final Rule. And this rule put a number of requirements across the managed care programs, but the one we will talk about today relates to network adequacy. And it said that Medicaid programs need to have specific requirements with respect to key provider types, so particular primary care specialties as well as other kinds of specialties, to take care of individuals in the managed care plans within the Medicaid programs. While they did not do a specific standard across all states, they left it up to states to create specific standards for the healthcare environment within each state. In California, we've had a long history of having different kinds of requirements related to our managed care programs. California has a long history of managed care, and our Department of Managed Health Care has been responsible for overseeing managed care programs across many different types of payers. And so not just the Medicaid or Medi-Cal program, but also private payers that have managed care plans. In California, the statute for network adequacy has changed at different times, with some of the most recent statutory language in 2017. And at that time, the language codified the requirements for networks, and it talks about the provider type and what is the time and distance requirement to be able to have access to services for patients. So there often can be different time and distance requirements depending on the specialty. So for primary care, somebody that you might want to see more often, your pediatrician, your internal medicine or family practice doctor, they may need to be closer as opposed to a specialist such as a cardiologist or a oncologist for cancer treatment may be further away because there are not as many of those. And so we need to make sure they're available, but they may not be as close by. So the time and distance may vary by provider type, and it usually is something that we measure from where the patient lives to where they'll receive services. When we think about that time and distance, there's different ways of measuring. Sometimes folks will talk about the idea of the way the crow flies, so just a straight line on a map. But for folks that live in busy metropolitan areas like Los Angeles, or live in rural areas where there might be a mountain range in the middle, direct crow distance does not necessarily reflect how long it will take to get there. So this adds a complexity where GIS can become very, very helpful. So we have a diagram that shows you these different components that really can contribute to network adequacy. And Nancy and Ahmed will be talking about this in more detail. But just so that you have a framework for thinking about this, we typically think about the two primary inputs, the business case around looking at the impact, the strategy for creating your network to make sure it's sufficient, what kind of provider access is necessary, and how do we look at the best way to locate those providers. Especially when folks or organizations are deciding where to put a clinic or where to have an office or different kinds of mobile outreach, they may take into account these various categories of information. Then there's also the regulatory requirements, which is part of what I've been talking about thus far. Those network adequacy reports that are necessary to send to the regulatory agencies, either the state or the federal entities, as well as then how do you address gaps. And there's also been an increased focus around social determinants of health and how those impact both needs and the networks. And that's the SDOH, or social determinants of health. So these four key components, population, providers, standards, and service area, really make up the four components of the geographic analysis for networks. And I am going to stop there because I don't want to take away from what Nancy and Ahmed will be sharing, but this gives you a framework that they will be launching off of as they talk about their specific areas. So first, I'm going to turn it over to Nancy to talk about her experience at the Veterans Health Administration. And then we will turn it over to Ahmed to talk about his experience with Kaiser, and then we'll have some question and answer time at the end. Nancy?
Thank you, Linette. Okay, so as Linette said, I am the director of the Geospatial Service Support Center, which is in the VHA. We are a Veterans Health Administration. We're a primary provider of geospatial data and services to all of VHA. The VHA oversees the healthcare needs of 9 to 10 million veterans, which makes it the largest integrated healthcare system in the United States. The healthcare is organized into veteran integrated service networks. We call them VISNs. And we have over 1,200 healthcare facilities across the United States. Those facilities include 900 or over 900 primary care facilities. These are outpatient clinics, 160 secondary care facilities. They provide specialty care, and then 52 tertiary care facilities. These are facilities or hospitals that provide inpatient care, more complex care, diagnostics, and surgeries. The VHA VISNs, the networks, are also broken down into markets and submarkets, and those can loosely be associated with catchment areas. So we have market planners that evaluate access to care and data at the market level. So historically, the VHA has used network adequacy and geographic access to care as a way of measuring service to veterans. And historically, that was developed using drive time to the nearest care facility, and also the degree of ruralness of the veteran. So for example, the standard back in the pre-Veterans Choice Program was 30 minutes to care for enrollees who live in a rural or urban area. And the target was to meet that 70% for 70% of the enrollees. So my office used geospatial, they used the facility locations, the residential locations of the enrollees, and a network data set and tools to calculate the drive time and distance to the nearest primary, secondary, and tertiary care facility. Those statistics, those numbers were generally averaged or aggregated at the submarket, market, and the VISN level so that leaders could evaluate and compare access to care. We mapped that so that there was a nice visual, and it was very easy to see what areas were meeting or exceeding the care access care standards, but also easy to identify those areas where there were gaps in care. So improvement was needed. And while those maps were great in identifying areas where there are gaps, it didn't really provide enough insight into where a new facility should be located. So we added, provided location allocation tools to our VHA market planners. And those tools allowed the planners to identify their area of interest, generally a market or a submarket, and to select potential locations for a new healthcare site, or allow the system to select an optimal location for a healthcare site. And that optimal or best location was defined as a location that would serve the greatest number of veterans, and especially veterans who were currently not meeting the drive time standards. So in general, outside of 30 minutes access to primary care. It also allowed the veterans to be able to measure the impact of a facility closure or relocating a facility. In 2014, our access standards changed, and that was a result of the Veterans Choice Program. So under Veterans Choice Program, we were mandated by Congress to provide care, primary care, within 40 miles. So our eligibility standard changed and our access standard changed as well. We switched from drive time to drive distance. And as part of that, my office continued to develop the drive time standards, but we were doing it more frequently, and we were doing it based on that 40 miles instead of the 30 minutes. So most of our information, the focus on access to care was that mileage versus the drive time. In 2018, the Veterans Choice Program was replaced by the Mission Act. And the Mission Act is maintaining internal systems and strengthening integrated outside networks. So quite a mouthful, but we shifted again away from the 40 miles, and we're now back to 30 minutes. So the standard for the Mission Act is 30 minutes to primary care and mental health care, and 60 minutes to specialty care. And that's regardless of whether whether an enrollee is living in an urban area, rural, or a highly rural area. And once again, with the Mission Act, the geographic data became a critical component to determining access to care and in managing and measuring those access statistics. But in addition to just the drive time, we've seen an increased interest in the specialty care fields. And those are the ones that are 60 minutes or are following the 60-minute standard. And in particular, we've assisted women's health, dentistry, the blind rehab services, and others. And the goal is to be able to provide information to the program offices so that they can make better decisions, especially as concerns access to care. Our hope over the next few years is that we will be able to continue to expand access to geospatial data and services, and in doing so, that we will be able to improve overall access to care for the veterans. Thank you.
Thank you, Nancy. And now we'll turn it over to Ahmed to talk about the experience at Kaiser.
Great, thank you. So my name's Ahmed, as Dr. Linette Scott mentioned. I'm a manager within Kaiser's National Provider Data Management Organization, which, as the name implies, manages provider data and all the related analytics associated with it. So Kaiser's a health plan, obviously, and we're also a delivery system. So we own and operate a lot of our network in lieu of contracting, although we do have contracts. And we have about 12 million members right now across the United States in about 9 states, which is a lot of people in a lot of places with a lot of providers. We're also beholden to a lot of regulators who nowadays, I think mostly all of them, have some kind of statute or regulation around network adequacy. So we have to kind of measure our compliance and submit reports all the time. And having software like ArcGIS, which is provided through Esri, helps with that a lot, you know, because it's automatable, it's scriptable, you know, we can plug it into our existing data systems, use that data for the various analytics, you know, in order for us to kind of generate these reports and stay compliant. But apart from just meeting regulatory needs, we also have to monitor our networks. Networks that are made of, you know, in addition to the hospitals and clinics, they're also providers, doctors, nurses, etc. And, you know, human populations are fluid. They change. People move, people retire, they find new jobs. So in addition to the snapshot that we provide regulators, we constantly have to monitor our networks to make sure they remain adequate over time. And so we end up repeating a lot of these analyses on a regular cadence. And again, having a software that enables that easily without having to recreate an analysis every single time is invaluable to us. In addition to that, beyond just meeting the regulatory requirement, our use of Esri software has been invaluable in network strategy, as Dr. Scott mentioned also. When we, you know, move into a new service area or provide a new service to a new area, having software that adequately and accurately assesses the accessibility of a network from a geographic standpoint is invaluable. Also, when, you know, breaking ground on a new facility or a clinic or whatever, you know, one of the, you know, amazing tools that Esri has is the optimal location analysis tools, in addition to the service area generation and all that. So we make great use of it. We wish we could do more. We have a lot of data. I think the main restriction now is hours in the day, where, you know, you need to find the room to kind of utilize all this data using these great tools to optimize our networks to the full extent. One other thing that I'll mention before I hand it back to Dr. Scott is, in addition to actually using this software ourselves, we've been able to create lots of custom applications using the software that we can deploy internally to our various departments, so that it's accessible now to even, you know, non-technical folks We manage the applications ourselves. They're built within the Esri environment. And they're available through the browser. People in various departments can click on them and use them to kind of manage their networks and their specific products. And it's worked very well for us so far.
Thank you so much. It's exciting to hear how the tool can really help support this activity. And admittedly, when I think about network adequacy, the tool that comes to mind first and foremost is GIS, because it is so geographically based and there is so much information to manage. So I'd like to ask you a couple of questions to understand a little bit more about how GIS has been used to help support your network adequacy work. So this first question is, if you could pick one thing that you would say you're most proud of in terms of how your organization has been able to monitor network adequacy and use GIS in that process, is what might that be? And Ahmed, do you want to go first?
Among the many things, I think my favorite is allowing our various contracting departments who are charged with maintaining the network and filling in, access gaps, providing them with the tools that take out a lot of the guesswork. So instead of, surmising that this provider, if they, contract with them or employ them, might fill this gap, they have a very usable app that they can use that, is managed and made by us with Esri tools. And they can just, take all the guesswork out of it and make an accurate decision that minimizes a lot of the kind of legwork that they have to do otherwise. So I think that's, one thing I'm very proud of in terms of using GIS for network adequacy.
Yeah, that's exciting. I know as I started working with GIS over a decade ago, it was not as easy to use as it is today. So there's certainly been a lot of advancements in terms of being able to put the data in the hands of the people who need it. That's exciting. Nancy, how about from your perspective?
So from the historical information that I've looked at, access to care was at least on the radar as far back as the 60s. But what I do know is that in the last 20 years, that VHA has been very proactive about embracing the technology. So when others were drawing a circle around a location and saying, this is the distance, the VHA was using network analysis to actually measure the drive time, because as we know, the drive time via the street network isn't necessarily the same as the crow flies. So, but they've not only embraced the technology, but we've developed repeatable processes. We continue to improve the way we process our data, and we focus on issues that are important to the VA. For example, rural health. Over 30% of our veterans live in rural or highly rural areas, and those are areas that are known to have greater access to care issues. We also make our data available. The drive time and distance analyses that we run, we make that information available across VHA so that researchers and program offices can use the information. So better return on our investment, greater sharing of data, and ensuring that we're all using a consistent data set.
So another question that I know many of us have been thinking about, especially given all of the things happening in our world today, is what do we do in the context of health equity and the focus of health equity? How has this impacted your approach to network adequacy and your use of GIS to support it? And I frame this question again because some of what Ahmed said around the depth of analysis we can do with some of the tools that we have with Esri's ArcGIS. I'm really curious how that has influenced your use of the network adequacy tools. So Nancy, might you be able to kick this one off for us?
Sure. So the VHA has an Office of Health Equity, and the office has dedicated staff, leadership that is focused on making health equity issues, bringing a greater awareness to health equity issues across VHA. They have developed resources and tools, including an online Veterans Geography of Opportunity tool. So in part because of their active engagement and efforts to make people aware, VHA has started to include health equity and healthcare disparity in some of the analysis that they're doing, and particularly when it comes to access to care and services. So for example, last summer we worked with an outside provider who was interested in collaborating with the VHA, and along with using wait times and the travel time, we also included several data sets in our analysis that represented healthcare disparities and areas where there is less access to care, less access to services. And that's important. And I think as we expand VHA's access to geospatial data, and as the access to information, socioeconomic and demographic information is more readily available to our end users, we'll see an increase in the use of the data to overall improve access to care, but also to help identify those areas where there are truly gaps, and perhaps change the way where VA locates their services and how that service is delivered.
Thank you. Thank you. Ahmed, how has this impacted your work?
Yeah, so it's a super interesting kind of field. Network adequacy is, in its basic sense, measuring the relationship between the population of providers, population of patients. And up till now, the focus has kind of been on just treating the patients as clones of each other and the providers as clones of each other, with no kind of distinguishing factors. I think tools like GIS help integrate other pieces of information into the mix. So instead of just clones of each other, you can segment the population, look at different areas where languages are spoken, health disparity, income, all sorts of things. Geography affects a lot of things about health. You always hear about how your zip code determines your life expectancy, whether you live in a food desert or you live close to a highway or things like that. So so much information out there that can be integrated into assessing the actual adequacy of a network. And I think we're starting to use that. We have lots of claimed information, lots of information on our membership that we could integrate into just general network adequacy. And we're starting to kind of dive into that, which is really interesting.
Absolutely, especially with the focus on social determinants of health and thinking about how we provide services holistically. I think we will see a continued change around what we think about in terms of networks and network adequacy. I know in California, we've been doing a lot of work around the idea of whole person care and services that wrap around individuals. And so those networks, as you said, there's a network of provider or a population of providers, a population of patients or people or clients. How we look at that is going to continue to expand to hopefully address these health equity issues. So one final question. What do you think will be the next big achievement this year for you in the context of network adequacy? Something that you expect will be something you can tell us more about next year. Ahmed, do you have something queued up for this year?
Well, I mean, continuing that conversation about social determinants of health, I think that's, for us, the next big thing that we're going to dive into and invest in. It's so important. And I think beyond just geographic access, issues of health equity are very important. So that's our big focus next year.
Right, thank you. Nancy, how about you?
We recently expanded our GIS enterprise agreement. So for the last 5 years, it has covered a small group of primary geospatial analysts, and we've now expanded it to cover all of VHA. That has opened the door to lots of collaboration, many more ideas. availability of the software and services among many offices. And so we're really hoping that that data sharing, the collaboration, the integration of GIS and the analysis will really help to build some new ideas, incorporation of new pieces of information that haven't previously been included. So I think it's the opportunity is there. We're definitely promoting the use of the geospatial analysis and tools, and we hope that people embrace that and that they use the information to make better decisions.
Great, thank you. Yes, we've done something similar as well at our Health and Human Service Agency here in California with an enterprise agreement. And it helps drive collaboration and partnership across the organization. So we're very excited as well to have similar experience, I hope. So thank you again for this panel and this conversation. It's been very helpful to hear what else is happening. And I hope this has been helpful for all of our audience as well. Thank you so much.